We'd like to welcome Dr. Nezam Afdhal from Beth Israel Deaconess Medical Center in Boston, Massachusetts for his grand rounds on hepatitis C elimination, fact or fantasy. Dr. Afdhal received his medical degree from the Royal College of Surgeons in Ireland and completed his fellowship training at the University College Dublin as well as Boston University School of Medicine. He is now a senior physician at the Liver Center at Beth Israel Deaconess and a professor of medicine at Harvard Medical School. His clinical expertise is in the management of complications of liver disease. Dr. Afdhal has published extensively on liver fibrosis and hepatitis B and C, and he is the recipient of many awards for contributions to his field. Please join me in welcoming Dr. Afdhal.
Thank you very much. These are my disclosures, which I have sent in advance. You know, what we're going to talk about today is what is the hot new area of hepatitis C, both research and clinical care, which is this concept of elimination of the hepatitis C virus on a global basis. And just to remind you, there's a little difference between eradication and elimination. Eradication is what's happened with smallpox, which is permanent reduction to zero of the worldwide incidence of smallpox, whereas elimination is really reduction to zero of the incidence of infection in a defined geographical area, but that you need to continue to intervene to keep it at that level. And polio is a good example of that, and as we all know, there are still around the world outbreaks of polio that take place. To understand the concept of elimination for hepatitis C, we need to understand where the disease is. And we often look at it as a disease that's got a global epidemiology, but what this slide shows us is the countries in which the prevalence of HCV really accounts for the majority of cases in the world. So these countries are responsible for 80% of overall global infections. And you can see that the countries with high populations, for example, China, has a lot of HCV, but for the percent of the population, it's relatively small. Whereas certain countries like Pakistan, Nigeria, and Egypt, where their population is much smaller, account for a huge proportion of patients because the actual epidemic in those countries approaches 10% of the population being infected. You can see the US is down there at around 6th or 7th. And the greatest advance that took place in elimination of hepatitis C was the downgrading by the World Health Organization of the actual numbers of patients with hepatitis C. So we always used to stand up and say 170 million people are infected, but now the World Health Organization says it's only 90 million. So already we've been extremely successful and eradicated almost 50% of hepatitis C simply with a stroke of the pen to reduce the actual global incidence. And the problem with this is that it's reflective of the fact that nobody really knows what the global incidence of hepatitis C, and that the epidemiological studies, just simply in the majority of countries around the world, aren't good enough. So is it 170, is it 90, is it something in between? And then, as a disease, it is a disease in which there are multiple different genotypes. There are 6 common genotypes, but a 7th and an 8th have actually been reported but not truly verified as being real genotypes. And these genotypes have broad distributions across the world in many different places. And genotyping a virus is a relatively complex PCR-based technique, and so it's not something that we really want to do, but we have to be aware that there are multiple different genotypes with different responses. And so the concept of elimination of hepatitis C really came through because of the effectiveness of all oral direct-acting antiviral therapy. We all know this. We know these so-called miracle drugs that came out for hepatitis C starting in around 2013 and 14 really have changed our approach to this disease. And most recently, there have been the development of what we call pan-genotypic single-tablet regimens. You really can't beat that. A pan-genotypic single-tablet regimen means that it doesn't really matter what genotype the person is. It's an incredibly simple algorithm for treatment. It's 1 tablet once a day for a fixed duration of time, which is 12 weeks, with a cure rate that overall is around 98%. So if you think about the concept of eliminating a disease, here is what we could consider to be a global hepatitis C killer, because it's straightforward. It really, really is straightforward. There are no other medications associated with this that increase toxicity. There's no ribavirin, there's no anemia, there's no other stuff. So this is truly a simplistic regimen, but it's 12 weeks in duration. And when we look at clinical trials, all of us should be very skeptical about clinical trials, because clinical trials are homogeneous, highly organized, highly controlled environments in which we strive to show the maximum efficacy of a drug in terms of treatment. Whereas in real practice, clinical effectiveness is far more important. One of the most amazing things about the HCV treatment paradigm today is that clinical practice and clinical effectiveness across a broad range of patients has actually demonstrated similar, if not superior, responses across the community-based treatment as it has in the clinical trials. There are very few treatments that actually do that. So if you think about it, most of the treatments that we say have a 90% chance of success, that drops significantly by 10 or even sometimes 20% when we go into more complex community-based patients who are not similar to those of the clinical trials. But there are multiple series, the VA, 50,000 patients, the Trio Healthcare Network, over 40,000 patients, that have confirmed the efficacy of these drugs in clinical practice, and it's been done across the globe. So studies from Japan, studies from China, studies from India have all demonstrated similar levels of effectiveness in community-based treatments. So the scene is set for the potential for an elimination strategy. And one of the keys that we also have to understand is what is the benefit of treatment and elimination of hepatitis C. And since the era of DAAs is relatively new, it's only 2013, 2014, here's data from the VA registry, very big registry, and the VA is leading in this area. It's absolutely leading. They have incredible informatics to identify their HCV patients, and they have an incredible proactive treatment program to treat all the hepatitis C patients within the VA system. And what they've already demonstrated in a period of 2 years is significant improvements in survival overall. That's all-cause mortality, includes renal-related diseases, includes cardiovascular disease, and they've shown an improvement in liver cancer-free survival. In just 2 years since the treatment paradigm with the DAA therapy became available. So really what you're seeing is a clinically significant benefit associated with treatment as well. Now, once these treatments came out, everybody got involved. So everybody got involved. That's our CDC, that's the World Health Organization, that's everybody. And the World Health Organization came out with Hepatitis 2030, they call it. And in this is the paradigm for what they're trying to do for global control / elimination of hepatitis. So what they want to do is they want to reduce the number of new cases of chronic hepatitis B and C by 90%. For hepatitis B, it's obviously through vaccination strategies, which have been successful, certainly in many countries, but that's what their goal is. So reduce new cases by 90%. Treat 80% of treatment-eligible people. So for hepatitis C, that means everybody. So treat 80% of people with hepatitis C and those that are appropriate for treatment with chronic hepatitis B, resulting in a 65% reduction in hepatitis B and C deaths. So this is the World Health Organization's stated goal for elimination programs for hepatitis C. So the first question we should ask ourselves is there any other disease, infectious disease, that has been eliminated utilizing medical therapy? You know, we just showed you two good examples, polio and smallpox, but they're both vaccine orientated. And so with vaccination, even with hepatitis B vaccine, we haven't eradicated hepatitis B. There's 250 million people who have hepatitis B in the world. So is there a disease that this has been done in? And in fact, there is one. And that disease is river blindness. So onchocerciasis was actually a significant global disease. 115 million people have been treated. The US, through Merck Pharmaceuticals and through the Carter Foundation, have been the absolute leaders in the eradication of river blindness from the world. It's actually been eradicated in many countries. The first country that eradicated it was actually Colombia. But across the rivers of South America and Africa, this disease has now almost disappeared. And the Nobel Prize in 2015 was awarded for the discovery of ivermectin, which is the treatment for river blindness. What's the difference between treating hepatitis C and treating river blindness? The difference is to treat river blindness, you only need one tablet. So the difference is in the actual what you're doing versus 12 weeks of therapy. But there is a predicate, so there has been success in a treatment that has resulted in an elimination strategy of a significant infectious disease. So we're in a situation where curing the individual is now easy. So here's our nice chart. When I started back in the 1990s, as did most of my fellow hepatologists in this room, we were using interferon monotherapy, and in simple words, it sucked. So it didn't work, and patients hated it. And we had cure rates that were reported as somewhere between 6 and 10%. Back in 1990, I treated 101 patients. I was at Boston City Hospital at the time, and I had no single responder. Nobody responded. And I thought, oh my God, this is such a lie. This treatment doesn't work, and none of my patients have responded. And then I treated a young Irish boy, and he actually responded. And I was like, oh, I got a responder. And I was rejuvenated in my 102nd patient. What was really stupid, and I tell this to the residents, is I never actually thought about what I was doing. And the reason why I failed in the first 101 patients was they were all African American. And the SVR rate with interferon African Americans was 0%. And in fact, it was 10 years later when we were doing the NIH ViraHep-C study, which was a study looking at the differential responses to interferon between African Americans and Caucasians, that we actually showed why African Americans failed to respond to interferon. And it was related to a pharmacogenomic marker, IL-28B, which was a marker of sensitivity to interferon. And I could have made that discovery if I was only smart enough to think 10 years before that, but I wasn't smart enough to think. So you should always be thinking about why you're not doing what you should be doing. But progress in eradication of hepatitis C on a world scale looks pretty abysmal. You can look at it there and look at the comparison, and it really is pretty abysmal. So there are issues with this concept of elimination 2030. And I've broken it down a little bit for you here and shown you across different regions of the world the potential for the number of people that are infected across African region, European, Americas, the Mediterranean, and then, the targets that we have. So the target of 90% of the infected diagnosed, we have a gap of 70% there. We've only diagnosed 20% of the people in the world with hepatitis C. So, we are now in 2018, so we have a lot of work to do to diagnose the rest of these patients. The 80% of the diagnosed treated, well, we're well below that as well. We have a big gap of 73% there. And when you look at the number cured, it's actually only about 2%. So lofty goals that don't seem to have been converted into what we want. And for real HCV elimination to take place, we need to have a rapid scale-up of public health approaches to close these gaps. And the biggest gaps to close are diagnosis and linkage to care. And I'm going to talk a lot about some very cool strategies, some of them coming from New York, that have been developed, not just in the US, but globally, to look at ways in which to affect this epidemic. So we'll start with the US, because it's always best to start with the worst. So the US has public health policy which nobody really understands, and political leadership which even less people understand. And although our physician leadership does point out what we should be doing for viral hepatitis, with very good reports coming out from the CDC, from the Institute of Medicine, about the approach to hepatitis, much of this has failed to be implemented. We do have an action plan that has been put out by the Department of Health and Human Services and the CDC for viral hepatitis. Sadly enough, the viral hepatitis division at the CDC has recently been decimated, since viral hepatitis doesn't seem to be a very important aspect of the CDC. And the goals are obviously the simple goals, and some of these are really important, just simple education of providers. We did a study where we used machine learning to evaluate the numbers of patients in New York, New Jersey, Pennsylvania, and the 6 New England states. So we took 9 basically East Coast states. And we used a machine learning tool to evaluate and to see what was the percentage of patients that were diagnosed with hepatitis C but never treated. And we identified 137,000 patients with known HCV that had never been referred to a gastroenterologist, a hepatologist, an ID physician, and had never received any treatment. Of those, 48,000 were in New York City, and I actually know the number that were at Mount Sinai Healthcare System, but I'm not going to tell you. And this lack of education means that you're not getting these people to the right places. We need to improve testing, care and treatment. Now, that is improved in the US. We're getting really good at that. Surveillance, we certainly don't survey high-risk patients and we don't access them well. And then we need to reduce viral hepatitis by drug use behaviors. Well, we are very bad at that. You know, as you have to be deaf not to know about the opioid epidemic that we have. But now we have, not in our cities, but in our rural communities, a secondary epidemic of hepatitis C related to the use of injectable opioid drugs. And the CDC estimates 35,000 new cases of hepatitis C per year, but that's way underestimation of what's happening out there. And it's happening in our poorer rural communities where access to these drugs has increased and there's a lot of intravenous opioid drug use. So, you know, we're not even good at that part yet. So if you think about it, here we are in the US, and what we need to do is we need to get our diagnosis rates up to that 90%. We need to link those patients into care, and then we need to treat those patients with a relatively straightforward and simple treatment. So let's look at how we're actually doing. So do we have an enhanced HCV screening and diagnosis? Well, we have guidelines for screening, and we have healthcare systems that are being very progressive about screening. I talked to Doug Dietrich yesterday at dinner, and you know, Sinai has a very progressive program for screening patients for HCV in high-risk environments, including the ERs, where there's a lot of patients coming in at high risk, and detection rates in those high-risk areas are between 8% and 16%. So the Beth Israel, where I work, we were incredibly progressive because we're a Harvard hospital, so we have to be very progressive. So we instituted right off the bat a screening program. And what we said is we're going to screen the baby boomer population, which is the recommendation of whom to screen. That's people born between 1945 and 1965, where the prevalence of HCV is supposed to be about 3.8%, which is higher than the 1.8% seen in the general community. So we instituted this, we had education, we put in a prompt, we actually gave credit for primary care doctors who send off HCV antibody tests, we did all of this, and our detection rate was 0.3%. And the bottom line of that is that rich, suburban, white patients don't really have hepatitis C, all right? So we were way below the actual national average for it. And, you know, in fact, what we should have done is gone and implemented it within our city-based hospitals and our city-based clinics, not at BI itself. So it's important to take the disease, take the action where the disease is. I'm going to talk a little bit about how people are expanding models of care in the US. A couple of years back, we had a think tank where we talked about how we really need to change the paradigm of care from Doug Dietrich to every physician that sees a patient with hepatitis C. We want to change the whole paradigm so that simple testing, simple treatment is the way to go, not referral to expensive, very cognitive gastroenterologist, hepatologist types. We need to look at our highly marginalized patient populations. We're not very good at that in the US. National strategies we talked about, and we need to remove all restrictions. And I'm going to talk a little bit about restrictions because that's another area in which we are so far behind the rest of the world. And this concept of access of HCV providers. So here is the actual care cascade in practice from experience in the US. This is a recent look. And we have diagnosed 50% of patients. So remember, we're trying to diagnose 90% of patients. So we got a little ways to go, but we're not as bad as some countries. Linkage to care. In linkage to care, we're really only getting about a third of the patients linked, and when they get to care, a significant proportion of those patients are actually not being treated. So we're not doing very well in the linkage to care side of stuff either. So what we need to do is make it simpler. We need to make testing, linkage, uptake, and adherence to treatment much, much simpler. And there are ways to do this that are really quite simple, and they don't require a lot of high-cost technology. The first one is always education and testing and prompts. And it's now in our system a quality metric that you should test for our primary care doctors an HCV antibody in baby boomers. And so we do need to figure out how to put that into healthcare systems. Linkage to care is where so-called care navigators come in. And in a lot of cities, this has been very well done. Cities like Detroit, where in their healthcare system, they have people that can help navigate the patients to the appropriate testing and then referral into the treatment uptake. And we need to alter how we do treatment. There's no doubt about that. The good thing is that adherence is not a problem when you have such a simplistic therapy as one tablet once a day. And unlike many other infectious diseases, adherence in HCV is probably not as important as we thought it was, and I'll show you some data for that. There's quite a lot of wiggle room for patients who don't take every single dose of their treatment. So the barriers to care really are that our current model is that you want people to seek out care, which means they have to be symptomatic or they have to feel they have a high risk factor or something. And that doesn't happen with hepatitis C. It doesn't happen. If you wait for hepatitis C patients to have real symptoms, you've waited far too long and they already have cirrhosis and they have advanced liver disease. So that's not going to work out. So what we need to do is to make sure that we have rather than the patient seeking out, us bringing HCV care to the community. So at Sinai, you have community outreach. Many places around the world have mobile HCV centers. It's absolutely amazing. I was in London, and at the London Hospital, which is in the East End of London, and it serves a very immigrant community, a lot of patients that come from Pakistan, Bangladesh, Afghanistan, and then some of the older English patients that were in long-term residents of the East End. They actually have trucks, like vans, that go around and screen. And not only do they screen, they actually have a homeless plan where they go to shelters where people are and actually do directly observed therapy and treat these patients within the homeless shelters. They have a much more progressive approach to going out and bringing HCV care to the community, including into homeless shelters, etc. So we need to decentralize. So this is us now. We're sitting in the middle of New York at Mount Sinai Hospital, and it's a nice big institution, and we're very proud of ourselves. But for hepatitis C, this is not where it needs to be. We don't need to fill a single room in the clinic here with an HCV patient, not one. Because we should have this completely decentralized. We should be in areas where there are STD clinics. We should be in areas where there are drug and alcohol clinics, primary health care, GPs. They need to own this disease. Jesus, they treat much more complex disease. I can't treat diabetes today. I'm too stupid to do that. But, we're not allowing our GPs to treat a Hep C, one tablet once a day for 12 weeks. That doesn't need a brain surgeon. It just needs one tablet once a day for 12 weeks. We need to be in our prisons and we need to be in our community health centers. And essentially, the good networks are trying to create these types of programs rather than have a centralized care system where patients are referred to specialists like ours. This baby boomer screening is taking off. It's slow. It's taken a long time to take off, but we are beginning to see some results of this. And the reason is that the disease is in this population. So it's not just that there's a higher prevalence, but if you look at it, the baby boomer population is 80% of all US adults infected. It's 70% of the morbidity and mortality associated with HCV. So these are the people that are dying from hepatitis C related diseases. So clearly it's where you want to be. And there have been a lot of different models that have been done, and the CDC put some of these together, and they really looked at how these were working. So the education campaign reached out and hit 1.2 billion impressions. That means people hitting on educational material. Screening that's taking place in urban and primary care centers, 9% HCV positive with some good linkage to care. Local public health, where there's been testing at STIs, jails, homeless, PWID residences, 16% HCV positive. Primary care low-income testing, 12%. Hispanic baby boomer testing done in Texas, 8%. Urban hospitals using an EMR navigator approach, this I believe was Detroit, again 7%, but most importantly here, 98% of those 7% were linked into care. That's really impressive. That's really impressive. So does it work? Yes, it does. Are we doing it properly on a national scale? No, we're not. So the models exist, but the will and the resources to do this simply are not there. This is one of my favorite ones, and this is the Cherokee Nation Health Service. So in the Cherokee Nation Health Service, what they did was they created, and the Cherokee Nation is vast, it's a huge landmass. And what they did was they had very low levels and rates of uptake and treatment. But what they did was they created an ECHO program. You know, ECHO is this distant learning and education program done through telemedicine. And it is a very good program for HCV care. They educated the PCPs in the Cherokee Nation and the pharmacists, created this ECHO program to help manage the patients with HCV, and you can see the absolute massive increases that took place in the diagnosis and treatment of patients with HCV within the Cherokee Nation. Jails. Jails are very interesting places. I've actually been to the jail where they filmed The Shawshank Redemption. I wasn't a prisoner, but I had a great time in there. It's a very interesting place. When you look at this, in jails, we have a very high rate of HCV positive patients, especially amongst jails where we have a lot of young patients jailed for drug-related offenses, usually young, usually African American. Again, we're not very good in jails at treating people. And I'll contrast that to what's happening in a country where they're taking elimination seriously. So you could look at our US, North and South Carolina jail system, and you look at about 12% of patients being treated. Sorry, I'm not going to do that. Now, the last thing about the US is that the US is not one country, all right? It's actually multiple different states. And within every state, there are multiple different healthcare programs. And we have the problem that's actually really unique to the US, which is the problem of multiple payers. So we have different states with different rules for access to care for HCV treatment, with different barriers to the access of care, and with different, very, very different start rates. If you live in New York or Massachusetts and you have hepatitis C, you have a pretty good chance of being treated. You know, it's somewhere around, New York, I believe, is about 70% of the HCV positive patients have access to treatment. In Massachusetts, it's about 80%, and the highest state in the country is actually Connecticut, which is the only one that's above 90%. If you live in Illinois or Tennessee, you're down in the less than 20% chance of being treated if you have hepatitis C. And the reason for this is that there are tremendous biases in access to care, and these have not improved. And this is one of the great, if you want, lies of our payer system, is that in 2013, 2014, when HCV treatment first came out, the payer community told the physician community that we will treat those with the most advanced disease, and once we've treated those, we'll treat those with lesser disease. And what we did was we used our network to look at starts across the country in actually I think in 49 of the 50 states. And what we were able to do is to look by different payers and by different types of insurance across who is actually getting treated. And what you see is that across the board, it's only about 60 to 70% of patients that actually have access. And it's worse from state to state. It's worse with Medicaid than with Medicare. Medicare is the best payer. The commercial insurers are in the middle. And it really varies tremendously from where you are. And you would think that maybe this is because they're still in the phase of only treating cirrhotic patients, but that's no longer true. In the US, we've treated almost 1 million cirrhotic patients in the last 4 years. And so we've exhausted our cirrhosis population. But you can see here that patients with F3 to F4, which is cirrhosis advanced fibrosis, still across the board in the US have about a 30% denial rate for access to care. And these are people that meet the guidelines for therapy. And so, this is a very, very difficult problem that's unique to us and resulted in some fairly strong warnings from the Department of Health and Human Services to our individual states about adhering to what Medicaid and Medicare are supposed to do. But this is not monitored, and this is really one of the areas in which political will to actually treat these patients is lacking. So, US, lack of political will, there's a lack of physician will. Sadly enough, many physicians still don't believe that this is a big and serious problem. And then lack of payer access. And so the only places that we're really good at are what I call special populations. So on a level of what we would call micro-elimination. So those same World Health Guidelines, but within specific segments of the HCV population, we will succeed. So where we're doing that is the VA. The VA really is totally leading this field, and the VA is very close to 80% of all patients treated and eradicated. It's very close. In fact, I was talking to some of my colleagues at the VA, and many of them said within a year we will have treated every patient within our VA system. So they are really leading the way. Dialysis centers. Dialysis centers, this should disappear from dialysis centers. Dialysis centers have become quite proactive in terms of treating these. And some of the big national centers have very good HCV programs with very aggressive treatment paradigms to completely eradicate it from those in the dialysis center. And what's really interesting about the dialysis centers is that there's now so much data to show that eradication of HCV is associated with an improvement in cardiovascular mortality and an improvement in renal outcomes. So really, it's another microenvironment in which elimination could potentially happen within the next year or two. And then the one that we've been extremely successful with, not just extremely successful with, but outstandingly successful with, is the transplant world. HCV is no longer a disease that's a problem with transplant. When I was a transplant physician for liver transplant, the number one problem we always had was, is this rejection, is this recurrent hepatitis C? And we used to biopsy everybody under the sun to try to make this diagnosis. Now there is no post-transplant HCV. When I say there isn't any, at the BI we do not have a single case of post-transplant HCV left. And I'm sure it's the same here at Sinai. Everybody has been treated, they're treated successfully, they have 99% cure rates, and this has been totally eliminated. And now, for the first time, HCV positive organs are being given to HCV negative patients. This is a fantastic advance. Every year, 3,000 to 5,000 kidneys are thrown into the garbage can because they're from high-risk HCV positive patients, and they're not given to people that need kidneys. But now that hopefully will change. And we'll be able to give HCV positive organs, not just to HCV positive patients, but also to HCV negative patients. And you've seen the literature that's evolved on that, even most recently this week. So high-risk populations are very important because high-risk populations spread disease. So persons with injecting drug use and prisoners represent a very important population. There's lots and lots of cool things being done for drugs. This stuff is being done by Dr. Litwin from New York. It's interesting stuff. This is where he creates models of care. You can either just give the people the drug and tell them to go away, standard of care if you want. You can do group, where everybody sits in a group, you educate them, you tell them to take their medicines, and they come back every month for group visits. Or you can do directly observed therapy. And they looked at a load of patients, and you can see that these patients are the high-risk patients. About 30% are homeless. Many of them drink alcohol currently to intoxication. and a lot of them have still active intravenous drug use, and they end up with pretty high cure rates, not the 90%, but averaging out at about 80%. Those with individualized care do the worst. But the commonest reason for failure is not virological failure, it's actually loss to follow-up. The patients disappear and don't come back for post-treatment care. But it's a model that, with minimal intervention can increase outcomes in this community. Here's something that was done in Vancouver that's very cool. These are called community pop-up clinics, but they illustrate the difficulty of treating this population. So what they did was they popped up, and literally it's a truck that pops up, and it pops up in a area where there's a high rate of utilization of IV drugs, and they go in there and they send in nice people who tell everybody, look, we've got $10 gift cards for you if you allow us to do HCV and HIV testing. And if they're HCV positive, they're offered on-site referral, multidisciplinary services, access to treatment right then and there. And they're also given lots of other things like needle exchanges and stuff like that. The sad thing about this is you would think that this is a system whereby patients might say, yes, I'll do this. Everything's being done for me. You've popped up in my local place. You're offering me treatment. You're going to put the whole system in place for me. But sadly, when they looked at this, of the 371 patients who were HCV positive out of this cohort of about 2,500 patients, only 26, so less than 10%, actually went on to agree to be treated, and only 16 achieved an SVI. And what this tells you is that for a lot of people, this is not an important disease. It's not important for them. It's not important for them and their lifestyle and what they're doing that they be treated for hepatitis C. And so what this suggests is that this is a population that can significantly spread the disease but doesn't want to have the intervention. Even though it's so simple and effective, they simply don't want it. That's a big problem. In certain countries, they get around that problem. They do it in a way that we can't do it yet in the US, but you never know what's going to come. They put them all in prison and basically shove the tablets down their mouths. Prisons. Prisons are interesting, very high-risk places, because if you have HCV in a prison and you come out of prison, you usually spread it, and if you don't have HCV and you go into prison, you have a good chance of getting HCV in a prison. So prisons are a breeding ground for hepatitis C. The Australians have a really cool program. They have a national elimination strategy program that I'll show you, but prisoners are a huge component of this. They have a nurse-led program that they've implemented. They're starting to treat all of the people in the prisons with simple treatment paradigms. It's highly effective. They're getting cure rates above 95%. And they're really, really being proactive in the screening, identifying, and treating of all patients in prisons. So it's one of the places that's highly progressive in terms of doing that. So let's get out of the US, which is depressing, and go to global and national programs, because these are usually more exciting. And the reason they're more exciting is that they often are single-payer systems. The government is involved, which means that if there is a strong political movement and will, that actually things happen. Unlike here where things don't happen. And there have been recommendations globally for how we should improve treatment into middle and low income countries. And then there are specific issues of these countries that are very important. And those issues are the same: diagnosis, linkage, and treatment, but their issues are a little different to us. Much lower disease awareness, much greater stigma. There's a much greater stigma for hepatitis C in certain countries than there is in the US. You go to Pakistan or India, it's highly, highly stigmatized. Shortage of diagnostic tools. Even if you give the drugs for free, if you have to do an HCV RNA or a genotype test, or even liver function tests, most countries can't afford the cost of that. They simply don't have the infrastructure or the ability to pay for it. This is a huge thing, and there are strategies that are being developed to overcome this. Lack of medical infrastructure, I'll show you countries where we've put in medical infrastructure. And a shortage of specialists, we don't need specialists, but any other type of healthcare provider is fine. And then, obviously, the cost or access to treatment. But the truth is that if you want to be treated for your hepatitis C, just get on a plane, go to India, have a nice 3-week vacation, get the HCV drugs for $60 a month, spend the remaining $25,000 of your copay on a nice vacation in India, and come back. So when you look at this, this is India. So this is an important concept. It's so easy to get treated for hepatitis C in India. I wasn't being facetious. It really is easy. One of my colleagues actually said you can buy it over the counter. There's generics, and it's relatively straightforward. But what's not happening in India is increased treatment uptake. So you've got increased efficacy with the drugs, but no uptake. So there's zero reduction of hepatitis C in India. It's still up there in the many, many millions. So this is the problem. So the disease awareness education stuff is all being done through governments, policymakers, NGOs. They are partnered in strongly with this, with the World Health Organization. And our CDC has been very active in certain countries. And then health systems are developing the infrastructure to deal with this. And then in countries that are really progressive, it's amazing. I was in the Republic of Georgia, which I'm going to show you some stuff about, where I run the education programs for the Republic of Georgia's HCV program. The Prime Minister goes on TV and has a test right then and there for hepatitis C, and tells on national TV, tells him, this is how you get it. I could have gotten it because I was sexually active when I was young, but if you've ever used drugs or ever done this and ever done that, and he has the test right in front of everybody and says, everybody go out and get tested. It's pretty cool. And so what the problem in these countries is the cost of the screening. It's a real problem. So, and in the US, we never do anything simply. So we do screening, and then we do confirmatory tests, and then we do genotyping, then we do disease staging, and then we decide whether or not the patient should be treated. So the yellow box is the real goal to elimination. And it's simply treat, cure, forget. It makes three assumptions. Assumption number one is that a finger stick test for HCV antibody is highly positive and is consistent with what you do for a serological test. And if you have HCV antibody, you probably have 90% chance of actually having chronic infection. So you treat everybody who has an HCV antibody test. You don't even test them for anything else. No genotype, no viral load, no core antigen, no nothing. You test positive for Hep C antibody by a finger stick or a salivary test, you get treated. You get the treatment, you have absolutely no tests during treatment, nothing whatsoever, not a thing. And then at the end of treatment, nothing. And so essentially, you're doing nothing except a salivary test or a finger stick. And why is that relatively good? You're picking up 95% of people that are infected. 90% of those are really infected, 10% are not. Tough luck for the 10% that are not. They're going to get a drug for 12 weeks with no side effects and no issues. You treat them, 95% of them are cured, 5% aren't. Tough luck for the 5% that aren't. You've created a paradigm that is simply like the onchocerciasis one. Just give it. Just give it to everybody who has a potential for needing it. And this is what we've been trying to develop in certain parts of the world. Now, this is not for every part of the world. I don't think you get away with it in Tennessee. Wouldn't be bad. But it is for many different parts of the world. So it's because the tests are so expensive and so difficult to do. So we've actually piloted this in Rwanda. We have a joint program between Harvard and Stanford, supported by Gilead, who's providing the free drug and the infrastructure there. And what they're doing here is they're doing a basically finger stick treat, forget about the patient, don't have any follow-up, and then look and see what the overall cure rates are. And this will actually read out sometime this year, and will show us if this approach does actually yield these very, very high cure rates. Now, here are the good countries. If you live in Iceland, which none of us do, it will be the first country to eliminate hepatitis C, without a doubt. There's absolutely no doubt about this. So why is that? Well, there are 330,000 people that live in Iceland, so it's not a big place. It's not a big place. And every one of those 330,000 people has had an HCV antibody test, every single one. And there are 1,500 positive patients, of whom chronic HCV is in about 70%. And they know the genotype distribution, and the majority of them are young people who have injected drugs. They have a mandatory treatment program, and they're doing it over a 3-year period. They're going to treat everybody. They've just finished year 2, so they're entering year 3. And The real key is that Iceland does not have a very mobile population. So you don't get a lot of immigrants into Iceland, and you don't get a lot of people moving out of Iceland. So Iceland just tends to be Iceland. And it's a closed system. And most of the people all live in the same place. So it is actually the perfect scenario for an elimination program. And so they're doing 300 patients per year. 16 they did 300, 17 they did 300, and 18 is the end of treatment. And essentially we'll get the report on the first country in the world to eliminate hepatitis C. Now, there are other bigger countries that are very cool. So Georgia is an example of how things have worked quite well. CDC, World Health Organization, we're looking for the perfect site for Hep C. Georgia was chosen, 9% prevalence. The idea was to create an elimination strategy that would be very effective for that population. They created infrastructure, screening, public health infrastructure, and they actually built buildings. And the CDC put a laboratory, a CDC reference laboratory, into Georgia. So an investment was made within the infrastructure. The government of Georgia, as I told you, went out and they actually created treatment sites all across the country. First of all, the CDC did fantastic epidemiology, identified where all the patients were. So if you look at this site, if you know where all the patients are, they're all in Zagdidi. So Zagdidi, there's a very heavy Hep C positive place, and so is Tbilisi. So they created these centers in the places. They put in the infrastructure. The biggest thing they had to put in, by the way, was the safes that store the drugs. So the drugs were donated by the pharmaceutical industry, and they had to put the drugs in the safes because the Georgia mafia wanted to rob them and sell them on the streets. So that was really cool. And they have an armed guard on it. So there are unique issues with every country, but that was really cool. And then they started their treatment program. They've been highly successful. So it's a population of about 3 million. They've screened already 500,000 odd people. They've identified many patients with HCV and treated them. They have extremely high SVR rates. This is their SVR rates. It's in the 98, 99% range. So they're doing just what they should be doing. They do it in these treatment centers. The problem is that they're running out of patients. And that is the global problem, is that you screen, but you have to keep actively case finding because you're just not getting all the patients. The other issue they have is unique also to Georgia, is that in the beginning, the Ministry of the Interior would go to the hepatitis C clinics and arrest the patients as they came out of the clinics, because intravenous drug use was illegal in Georgia. So the Department of Ministry of Health and the Ministry of the Interior had a big battle, and the Ministry of Health won, and they decriminalized the treatment of these patients in these hepatitis C centers. Just to show you what an impact this can make. So the US government are involved in here. They actually like Americans in Georgia. The second thing is that this one program was the program on which the Prime Minister of Georgia won re-election in their elections in 2017. It's the most popular program in the country of Georgia. So clearly, we do very well as a nation when we give medicines instead of bullets. So that's something that perhaps we should be thinking about. Finally, I'll end up with Egypt, because Egypt is a cool thing. This is a global view of the Nile, lit up at night, a tremendous, fantastic river. If you ever get a chance to go down it, it's really cool. But it has a unique healthcare problem in hepatitis C related to the Nile River, and that was schistosomiasis. So schistosomiasis was endemic down the length of the Nile, and the Egyptian government started a program of injections of antimony for the eradication of schistosomiasis that resulted in the world's largest prevalence of HCV. So the prevalence of HCV in Egypt is around 12 to 14%. And it is huge because it was iatrogenically transmitted in the 50s and 60s. And Egypt has a significant problem with HCV. What Egypt did is they, again, put in an infrastructure. They had a national plan. I went on a Fulbright to Egypt and helped set up their liver center and their national plan for HCV eradication. And this national plan created all these HCV treatment centers, and then they created a paradigm whereby they had such a huge population of HCV patients in the 12 to 13 million patients. So think of the US at around 3 million. Think of the resources that Egypt has compared to us. And they created this national plan where they started a registry, which started on the 18th of September 2014. And on day one, 103,000 patients signed up. Day two, 51. Day three, 51,000. And they soon had 1 million patients sign up, all right? So this looked really good. They were getting all these known HCV patients to sign up. This is 2 years later. They're getting about 1,000 patients a day. It's significantly reduced, and it's a reflection of not being able to find and screen the patients. This is the problem. This is their 1.2 million people signed up, registered. Look at their start treatment. It's still abysmal. It's still abysmal. You might say, well, this is cost. How can Egypt afford this? Egypt has generic drugs now. The cost of treatment in Egypt is about $60 per day, and it's anticipated that $60 a month, and it's anticipated that it'll drop down to about $45 per month. And they're using, for genotype 4, which is their predominant genotype, they'll actually be able to use 8-week treatment courses. So, you know, it's not just the cost of the drugs, it's the fact that this is hard to access people and to get them into care. Final thing I'll point out is Physicians Unite. You know, we live in a world where people publish things, and then those things that are published has tremendous impacts across the world. So this is an article from The Guardian based on an article that came out from the clinical trials unit at the Cochrane. So what the Cochrane did was they looked at all the clinical trials in hepatitis C. So I don't know if any of you know what a typical Hep C clinical trial looks like. It's 12 weeks of treatment, 12 weeks of follow-up, that's it. That's all you do. It's 24 weeks for a patient. It's really relatively straightforward. And it's all short-term. And they looked at all these studies, and they looked at only the randomized controlled clinical trials that we did. And they said, it's never possible to show that something does not work, but there is no evidence that they do. The hepatitis C drugs don't work. Okay, so here we are, us, curing 99% of people and getting rid of hepatitis C, and here's the Cochrane group telling us that the drugs don't work. So what they did was they said, but you never showed an improvement on survival in your randomized controlled clinical trials. You never showed a reduction in liver-related outcomes. They're 12 weeks. They're 12-week studies. That's all they were. The endpoint was eradication of the virus, which, as we've shown now, 2 years later, as I showed you in the VA, results in improvements in all-cause mortality and things. But they published this. And that publication led to certain countries actually saying that the DAA therapy doesn't help patients with hepatitis C. And that is a message that is inherently wrong. And so the Cochrane asked me for a whole load of data from a couple of my clinical trials. I wrote back a very interesting letter to them. So in summary, we're not doing it. Less than 2% of the global population is being treated. The HCV care cascade is not great. We have failed in this country for patient and communities to be fully engaged to get the full benefit of treatment. Barriers still exist in the US and across the world. I'm definitely against a shortage of specialists. I don't think you need anybody specialized, but you do need infrastructure. And that really, it's a grassroots thing to really get into this, to really be able to do this. And sadly, right now, HCV elimination, fact or fantasy? It's probably fantasy, unless you live in Iceland. Control may be possible in some countries. We really will have to step up the gaps, which is really case-finding screening on a global scale, and that's highly unlikely to take place. You know, we can't even do it amongst our own IVDU and prison populations, which are relatively captive and well-recognized populations. And then it's highly unlikely that in many of the countries in which the disease is endemic, we'll be able to do the basic behavioral social changes that are necessary. Thank you very much for your attendance.
Question.
Great. Simple question. You didn't say it explicitly. Do we really need physicians involved in the care plan, even in the U.S.?
No. So in countries like Australia, It is completely done through nurse practitioner PAs, and they do a great job. And they have, they do the flying health service too, so they put the PAs on the planes flying out to the big ranches and treat the people. In the UK, it's a completely nurse practitioner PA run program. The specialists, literally, all they do is say treat. So they do the intake, they say treat, they never see them. In my clinic where we treat a lot of patients, I will see the patient for one visit, that's it. And that visit really is just to go over the whole thing, say you need to be treated, look at all this stuff, make sure that if they need screening or stuff for HCC that it's all done. And then I really never see them again.
Is there any evidence of resistance anywhere around the world developing?
So in the beginning, we did have issues with resistance. And it was related to the efficacy of the treatment more than the virus itself. So the virus it survives by a high level of replication, as you know, 10 to the 13 per day, and it has no proofreading. So at any time, there are many, many clones, some of which are resistant to the common drugs. But the combinations that we use today, particularly with a NS5A, which is a very potent drug, and an NS5B nuke, which is what sofosbuvir is, those combinations, the one of sofosbuvir and valpadosvir that's in the Epclusa combination, that has not had almost any resistance to it, significantly less than 0.5%. And we haven't seen global resistance. What's amazing about this disease is that clinical effectiveness is as good, if not better, than efficacy. I've never seen a disease like that we see such good results in the community.
Given the last 2 points you make there, if there's reinfection and don't change behavior, wouldn't there be enormous recurrence of infection? So if you don't
It's much less than you think. So the Europeans are very good on this because they look at the 2 highest risk populations, which are active IVDU and men who have sex with men. And they've done some really good studies on this where they've looked at the reinfection rates. And the reinfection rates are really relatively low. It's about 1.2 per 100 patient years. They're really pretty low, but they have better programs. They have needle exchange programs for the IVDUs, and so they help with those patients. One of my friends in London told me that he has a patient who's actually been reinfected 12 times and cured after each infection. So I find that kind of funny.
So from the basic research side, I think the availability of these drugs really has put a damper on vaccine research, as I understand. How transformative do you think a vaccine could be?
I focused on the treatment side here because that's what we're doing in globally today. But the reality is that we should be spending so much money on vaccine research. We should be because without a vaccine, it really is fantasy. So if I was to say where HCV dollars should be spent today, it's all on vaccine research. It's very funny. HCV was a very good target for NIH funding about 10 years ago. I mean, some of the biggest liver disease programs were all in HCV. We did all these long-term studies and outcome studies and low-dose interferon studies. We had a lot of HCV funding, all right? But it's now almost none. It's just complete, because they look at this and say, these drugs cure HCV. Why do we need to have any more funding for this thing? But vaccine is where it's at. The vaccine is proven to be extremely difficult. And, I think that for this disease, a vaccine that was even 70% protective would be a worthwhile vaccine. I don't think that we're going to get one of these super vaccines, but if we got something that got up into that range, we still haven't gotten up into that range yet.
Thank you very much. Thank you.
Thank you.